Okay, first of all, I want to thank everyone for coming in to get this education. I'm going to give you a little bit of why we're doing this today. We all know that here at Northern Nevada, we are an accredited chest pain center. And what comes with being an accredited chest pain center really says that we have to have our processes, procedures, and the team all on board to be able to treat our patients in an expedited fashion, okay? Over time, we have had a lot of new employees come on and join, and we try to do this education just to get everyone on the same page. And that's really what our goal is, okay? Make sure that we all are treating our patients the same way. Does that make sense? Okay. So, we are, as I said, an accredited chest pain center. Our first line of treatment for our patients is PCI, okay? So, that's what it is. Here in our department, or the cath lab, we actually have 2 fully staffed cath labs with all the tools, capabilities to treat our patients. We do that on a 24/7 basis. And what time were you guys here last night?
11.
11 o'clock. So the STEMI was called last night. So just an example that we do this on a 24/7 basis. And so thank you for doing that. As part of the chest pain center, they have some rules. And one of those rules is that when we treat our patients, we have to ensure that we get that door to balloon time done in less than 90 minutes. And we have to do that 85% of the time. If we don't do that, we are actually risking our accreditation, okay? So when you hear the cath lab people kind of excited about that and trying to push, or you hear leadership doing that, that's the why we're doing it. So, one, we want to treat our patients for the best outcome, number one. Number two, we've got to meet that metric, because if we don't meet that metric, we're in jeopardy of our chest pain center, okay? Today, just so we're all on the same page, we're meeting that metric 75% of the time. So there's some concern that we're actually having. So again, not to beat it to death, but that is why we're having this class, to make sure that we all get on the same page, we're all doing the same process to treat our patients, all right? Again, our primary way of treating the patients is through PCI. All right, now part of that, treating the patient for a chest pain center, is looking at acute coronary syndrome. Now, I know everyone in this room knows that we have the 3 categories: stable angina, the non-STEMI, and the STEMI. Now, the way to treat that is obviously through rapidly identifying those patients who are having these situations. And how is that done? Well, we know that's through the EKG. So we've got to make sure that we get those EKGs done in 10 minutes, okay? And what does that mean? It means we get done and have them read. So we need your help making sure when they get read and we take that EKG, that we get it to the ER physician and they actually will circle STEMI and sign and date it. All right, we need them to do that because we use that time to help us measure how well we're doing as one of our metrics. Okay, and you probably can't see over the slide projector there, but we have 2018's numbers on there. And really what it says for AMI mean minutes door to EKG for those groups, it looks like we were averaging 8 minutes. However, we only met that 73% of the time. So it's telling us we have a little bit of opportunity, okay? We're not the only ones in the nation that are looking at that, or struggling with that. But that's, I just want you to be aware that identification as soon as possible is key, so help us with that EKG. In the emergency department, we actually have an algorithm that actually talks about the flow of the patient as it goes through the whole process. So, and just trying to think if I'm going to go through all that. But let's go through it, because that's why we're here today. So the patient, what happens when the patient comes in through EMS? This is exactly one. They can call in, and we call that a STEMI alert.
We get a pre-STEMI alert. We call you guys. We get our stuff together, aspirin, 2 large bore IVs, paperwork, consent form. Get the EKG in the room. Be ready for the patient when they arrive. Make sure all of the things are coming together.
Exactly. Just want to make sure that we actually call the cath lab if it's pre-STEMI alert, like you
And call
guys.
the cardiologist.
And call the cardiologist. When we do the one call, exactly. That one call system that you guys tell the ward clerk to activate goes to the cath lab team. It does not go to the cardiologist, as you just mentioned. What we expect is that the doctor actually calls the cardiologist, has that one-on-one, and they talk together, okay? So what happens if the patient comes in through the ER waiting room?
All of our chest pain patients get an EKG within 10 minutes. And at that point, we would then begin a STEMI alert if indeed that patient had a STEMI identified by the physician.
Exactly. And we all know in the admitting department that when the patients walk in, they have this process where there's a sign out there, but not just a sign. The registration clerks know to ask the questions. Are you having chest pain? And they have a list of them up there that will help guide them to help identify. And if indeed they have some sort of chest pain, we're going to page that overhead. Exactly. All right. So what are some of the factors for coronary artery disease? Things that you guys already know are age, smoking, hypertension, high blood pressure, family history, your lipids are off, you're diabetic. We know that the course of chest pain can mimic ACS, other things that can mimic chest pain. People who have pneumonia, pleural effusions, PEs, neoplasms, aneurysms, some musculoskeletal things, other disorders, arrhythmias, pericardial perfusions. So in short, there's a lot of other symptoms that mimic having chest pain, okay? And I'll tell you, that is one of the main reasons why we have a chest pain center. Years ago, when we did not have a chest pain center, all those lists of patients actually bypassed the hospital because they mimicked chest pain. They went somewhere else. By having the chest pain center, in addition to treating the true chest pains, we're able to capture that whole group of people as well, and our community deserves it. You know, we talk about signs and symptoms of the chest pain. Up here, we talk about atypical signs. I think everyone's familiar with the typical signs, but the atypical signs are the ones that we really try to zero in on because they're hard to find. Fatigue, lethargic, being anxious, pain that travels down the back or throat, jaw, or the center of their back, one arm or the other. Women also tend to deny pain, but rather describe burning or aching sensations. In the ER, can the ER tell me what age for abdominal pain, what age do we do EKGs at? What is it?
Over
50, exactly. Over 50. So if a patient comes in with abdominal pain and they're 50 and above, we should be getting an EKG. That's in protocol somewhere. some of the things you need to know as a chest pain center. First of all, we've been full a lot. And you guys know that NNOC for chest pain, STEMI, steeple angina, we're never on divert. So when you get that call and it's for a STEMI and you know we're on closed divert, one of the rules says we can't be on divert. We have to accept that patient. Okay? Obviously exception if we're on some sort of major internal disaster, things like that, that would be an exception. But, just so you know that. When EMS calls with patients who have possible ACS, the clerk will page EKG machine to the appropriate room in the EKG on arrival. So really what that means is we learned a while back is one of our downfalls in the ER through looking at case studies was EMS would bring those patients in, bring them to the room, but what we really forgot to do at times is to get that EKG, and the times actually marched out, delayed our EKG times. So this is just a reminder, when EMS brings them, that room still needs to have that EKG intent as well. All right, STEMI patients must receive reperfusion therapy as soon as possible, okay? I think we all understand that. Triage protocol exists for simultaneous presentations of STEMI patients. So what happens when we have one on the table or two on the table when you get one in the ER? I'm here to tell you it has happened a few times, and it seems like they all happen at the same time. Really what our protocol says is that the ER physician will talk to the cardiologist, and then right there they'll make a risk assessment on what we need to do. Sometimes we will hurry up the patient on the table and get them out to bring that patient in. That's one approach. Or the other approach that we just need to, and we do that often. The other approach that we need to consider is fibrinolytic therapy, okay? So that may be an option as well. But that's between the ER physician and the cardiologist, so we will get those guys to talk to make that decision for what's right for the patient. The national standard for door-to-balloon time, we all know is 90 minutes, right? But here in this community, we actually look to have that door-to-balloon time in 60 minutes. Now, Shannon just came back from the ACC class, and I guess, what she tells us is they announced at that meeting that they're getting ready, I'm not sure when, but to move the door-to-balloon time, the national time, down to 60 minutes. So that's coming. So, and that has been what our goal is, and that's one of the reasons why we have it there. So we'll be ahead of the game. So if that patient in the ER is going to be there for over 30 minutes or so, it's going to take a long time to get to the cath lab. We need to consider fibrinolytic therapy. All right. Right. Dan, did you want to come talk about these? So when we have our STEMI program here, and the way we laid it out with Dr. Inda, it was designed a long time ago, is how do we meet a 60-minute time? And so we came up with some simple concepts. We broke the process up into 15-minute increments. 15 minutes in the from the time the patient gets into the door to the time they get that EKG and assess. The next one would be the time, 15 minutes it takes ER to get them ready. Dan will talk more about that. Then 15 minutes in the cath lab to get them ready. 15 minutes for the doctor to get it done. 16 equals 60 minutes. So the structure seems pretty simple, so we kept it simple. We'll go into some more details on how that works. Go ahead, Dan.
All right, so we've got two scenarios on a STEMI patient, coming in by ambulance or coming in through the door. If they're coming in by ambulance, we've got a few minutes to kind of get ready. So first things you want to do when you think STEMI is the STEMI box and the STEMI packet, okay? So chest pain from a STEMI is from a lack of circulation to the heart, right? So wrap a rubber band around your finger when you get that STEMI in, and it starts to hurt. What we're trying to do is get that rubber band off as soon as we can, which is what the cath lab is doing, restore circulation. So in a few minutes, that finger starts to hurt. So that's why we're hurrying, okay? So just because something is important, like the STEMI team, doesn't mean it has to be complicated. A lot of the stuff that we do is pretty straightforward, and it's kind of a team effort. And there's mechanical things that we have to do, and then there's interventional things that we have to do. The mechanical things is kind of geared towards the tech, which is a very important part of that STEMI team. We've got to get that patient undressed. We write the time on the foot, put the pads on, and things like that. So what I did was, there's not too many things more important than flying an airplane with 300 people, right? Even though those pilots do that 20,000 hours, they still have a check-off list. So what I thought was, why don't we do that? Because you might work in the ER for 2 years and not work a STEMI. And it's like, what do I do? What do I do? So what I did was I came up with 3 cards. And so each person in that team, we're doing a 3-team. The tech, the patient RN, and then another RN to kind of help that patient RN. That patient RN, and the roles need to be delineated. Don't assume, well, I thought you were the patient's RN. No, I thought you were. No, I thought you were. You want the RN that knows the most about that patient to go with that patient over to the cath lab, because that cath lab is going to be there, and they're going, okay, what's the history? What is this? You know, oh, I don't know, I didn't get that. So sometimes the triage nurse might be that patient RN, okay? You might be in starting an IV. You're in there 10 minutes on another patient. You come in the middle of the stream, we don't want to have to play catch up. So then maybe you might have to be the triage nurse for a few minutes while that person that has been with that patient the longest goes with that patient to the cath lab. And again, don't assume that. It's very simple to just say, you're the patient RN, of course the tech knows he's the tech, and then you have another RN kind of helping you. So these are going to be in the STEMI box. Make yourself familiar with them, and just look at it. Just, okay, these are the things that I have to do. So I think this is going to be a help, because there's no guessing like, oh, who does this or who does that. Also, it's important to become familiar with the STEMI box. Look at it when we don't have a STEMI, so you know that we've got aspirin in it. We've got nitro, we've got labetalol. And again, another one of the mechanical things that a lot of times is overlooked is, do we need to shave that patient? The tech needs to be doing that, putting on the pads, getting that patient ready to go, because we want to get that rubber band off of that finger as
Can
soon
you
as.
have these cards around Dan, so we can
This is,
look at it?
yeah, we can put it around. This is brand new, so and there's a different color for different for the different roles. In the STEMI packet, there's the consent, and I know there's some confusion about having the consent signed before the cardiologist arrives. The cardiologist needs to talk to the patient regarding this consent before it's signed by the patient, is my understanding.
Yeah, so what we're asking is if that patient doesn't want to sign that consent, or the ER physician doesn't want, we do want to get the paperwork filled out, okay? And at least at the time, we will have that paperwork, and then we can actually have it signed. But be aware that if it is a true STEMI, it is considered an emergent event, and that is one where we don't need a consent. Okay, that's our process.
Wait.
No, go right ahead.
You wouldn't send somebody to get their appendix taken out without them talking to the surgeon. Like,
Yeah. And what
That's
happened,
an emergent condition too.
no, that's a great question.
Or torsion.
It's not, it's, the consenting process needs to be that the patient is spoke to about the risks, benefits and stuff from the procedure doctor. The ER doctor is not the one doing the procedure, the ER doctor is not the one that's the expert in this field.
Yes. And then I will tell you what happens, and we do follow that process. We do. You may not see it.
No.
I get yelled at every time I bring
No, we
somebody over
don't.
without a consent and they haven't seen a cardiologist.
Yeah.
So what happens prior to the exam is the cardiologist actually does, before they start, they actually walk in the room, walk up to the patient and have that conversation to answer all those questions.
But, and then it needs to get signed after that.
Yes, and we can have it signed after that, yes. All we're asking you to do is just fill out heart cath when possible.
That's already filled out, it's already filled out.
That's all we're asking.
It just needs to be signed.
We're all on the same page. And
So then we're not having them sign until they talk to the cardiologist.
It will go over with the patient's chart, unsigned and signed in the
That
cath
lab
lab.
nurse will sign
Just
with
to be
that
clear.
cardiologist.
That is correct.
Okay.
Unless the
Unless they're
cardiologist
at-
comes in and
Right,
talks.
the
to
bedside
them.
in the
Yeah.
ER, that's
Yeah.
what-
Then we'll hand the patient a pen, absolutely.
I mean, the bottom line is there's been a lot of confusion, I think, on both sides, from the ER and then from the nurses in the cath lab, speaking as a nurse in the cath lab. And so we get the heat on why wasn't this signed? And so I think that the most recent conversations have been, if it's a true STEMI, like John said, all paperwork doesn't need to be filled out. Now, you're right, the doctor, the cardiologist, no matter what the situation is, will always come in and talk to that patient. Always, before the procedure begins. So that's that conversation now, because we're there attesting to that. We would then have them sign the paperwork, but it's not necessary anymore, because it's an emergent situation. So when you guys bring in a STEMI patient from now on, and it's a true STEMI, we're not gonna be asking for the consent. Moving on.
Great question. Thanks
Just
for
to-
bringing that up.
Yeah, break that
So we're-
tension.
So
'cause
we're
there's
all
a
on
lot
the
of it.
same page.
So we're not signing.
No, I mean, if the cardiologist is there and
Well,
you
yeah,
see that and you're part of it, sure, and if the patient, if you guys have that
That's
time,
not
but
our
it's not,
problem.
but it's not required.
I mean, that's not what the point is when we don't see the cardiologist at the bedside in the ER, in our
Right,
unit.
then just keep moving
Right.
forward.
Ruby.
Moving forward.
Got it.
Thank you.
Let's make this.
Great point.
So the primary RN is going to be the primary voice to that patient. I think it's a good idea to just have one voice. Too many voices, it's like talking to a psych patient. Too many voices, it's confusing, So one voice, you have another RN helping you, you've got the tech doing a lot of the mechanical stuff. Also, the primary RN is getting that information into the computer. If they come in by EMS, preferably they've already got 2 IDs. If they don't, then the other RN that's helping you can start that second line. Another consideration when you have a STEMI patient come in is the family member, because they're freaking out. And so I kind of like to have that house supervisor say, kind of grab that family member and say, hey, look, this is what we're doing. If the supervisor's not there, it's very easy for that patient RN to explain to the family member. You might have to use that family member to get history. When did this start? Has it ever happened before? So anyway, I think the main thing is, if you look at those cards, it makes it pretty simple. Again, it's not, just because it's really important doesn't mean it's really complicated. Many times the STEMI patient is the easiest patient we have, because they're in and they're out quickly. So once we get these tasks done, now the unit clerk's got a whole different thing going on. Also, we have a core measure, but Shannon was saying that she doesn't use that. Are we still having to fill out that core measure?
I believe that she still wants us to fill out some of the forms and then for them to come to us, because there's a couple of checks on there that we need to, but she can, as far as I understand, she can always go back and.
The main thing is
Core
getting the
measures
things
after
done that we
that.
have to get done. If we have to go back and do the core measure, that's one thing. We're trying to cut down our time.
The fact is that she's having a hard time knowing which patients actually have come in as a STEMI, so it's our way of collecting that paperwork for her and then passing, here's a STEMI, here's a STEMI. And the reason why we know it's a STEMI is because we're giving her that paperwork with the patient's name and the information and some of the times on there.
So we'll talk a little bit about that paperwork. One of the things is when we call that STEMI, it is a code situation. In that code situation, our nursing supervisor actually shows up to all of those exams, or all of those codes, if you will. And STEMI is no different. And so in the ER, similar to Dan's cards, some of the roles, but we have a checklist up here. And it's really, the house soup is the one who comes in and helps facilitate to ensure that all these steps are being done. And we created a checklist here, one, and then it's bold there. It
And it's
says-
in the packet.
which is in the packet, and it's cath lab ordered into Cerner. It sounds simple that some places that order, but without that accession number, it's hard to move that process forward in the equipment, and it kind of holds us up. So as soon as we can get the doctor to place that order. The other one is make sure that the paperwork is ready for terms of consents.
And that, what John is talking about coincides with the cards also.
Can you pass those around?
Yeah, yeah, and we'll make those more available. So, and again, they're different colors, there'll be more, these are just the only ones. You're gonna wanna say, well, why don't we add this, why don't we add that? We're trying to make this simple, these are the things that have got to be done. Because if I gave you a card and you got 30 things on here, it's like, holy shit, you know? So, that's why the simpler, the better, all right? So, there's going to be a set in the box, but then there'll be other ones around as well. But again, if you've never done a STEMI, you can do a STEMI with those cards, which coincides with this sheet. Okay, so that's why, and we have people that work irregular, you know, and again, haven't done a STEMI. So you can get through it with those cards.
And some of the things on there like this is right arrival time on the foot. And ask the questions, did you get aspirin? What time? What was the dose? Let's see, is the patient changed? What's the vital signs? Did you start two IVs? In which arm? The left arm. Very good, because we do the 80% of our procedures that we're doing today are radial, and so we go through the right arm. So those type of things. And this is the checklist, or that to help the nursing supervisor facilitate through the process.
Just got a question back to the order. Are the ER doctors going to be willing to put the cath lab order in?
Yeah, I don't think there's a problem with that.
I think they always do.
Yeah, that's not a
Sometimes they
problem.
wait till the cardiologist gets there.
They shouldn't be doing
There's a lot
that.
going on and they
Shouldn't be doing that.
So I just wanted to point out that the nursing supervisor's role in this, to facilitate the process. She can use this checklist to help kind of go through it real quick to make sure that things are getting done, or it's a guide for her to make sure she can help her dig in and get those things going. Also at the time, you guys are probably familiar with this form, and this form is the timesheet. It is really filled out by the ward clerk. She pages out the STEMI, and when she pages out the STEMI, the cath lab team, physicians, et cetera, will call in, and it really just documents the time in which we called. Another tool that we use to document. And if these forms can follow the patient, that would be beautiful. As Val was saying, it's just an opportunity for us to get that information back to Shannon for statistical reasons. All right. Hey, Dan?
Yes.
I think this is your blue card here.
This is all the stuff we already talked about.
Yeah,
The
this
next
is,
3 slides we've already talked about.
yeah, this is pretty much what is on those cards that are being passed around. Okay. You see. We talked about putting time on the foot at this time. I know there's some conversations going on about putting a clock in ER that coincides with the cath lab, so we can have a consistent time as an idea.
Ours is timestamp when they arrive.
Timestamp from your,
Yeah.
yep,
I don't know how that would work.
we're looking at.
I think the problem is that some of the EKG machines aren't the same times as our computers as are on the walls. So sometimes I'll notice that there's 2 or 3 minute difference as to what the computer says, as to what the EKG machine says. So sometimes that could change our times a little bit when we're looking at little.
Okay, thank you, we'll check into that. We're supposed to be checking that weekly to make sure the times are coincide.
Who does
so,
that?
Loretta does that. This is also the blue cards, talks about the checklist. Third 15 minutes.
Okay, so I'm Val from the cath lab. We take ownership of this slide here, the third 15 minutes. And we usually do this prior to us leaving every day, or at the end of a STEMI, so that we're ready for the next STEMI. So basically, every day before we leave, we need to have our cath lab ready to go. Clean sheets on the table, clean pads, we have to have all of our packs, all of our instruments all ready to go and open. We need to make sure that all of our electrodes and cables are ready, everything's clean. We have our injector, which is our contrast injector, ready to go with our heparin saline and our contrast. Dry setup, not spiked, because we have a certain time where it's allowable to be sitting there over the time. We need to make sure that our rooms are stocked with enough fluids for every situation, make sure, you know, on a daily basis that our meds are not expired. And that we know that our roles in the cath lab, we follow the call list, and we do everything that we can do to expedite you guys coming into the cath lab. So sometimes we have 4 roles for staff members, sometimes we only have 3. So the ones that we always have is a scrub tech. The scrub tech's gonna be the one focusing on the table, making sure that when you guys are coming in, if the table's open, make sure that you're not too much close to the table to make sure it's as sterile as possible. And then they're gonna be helping the doctor scrub in, get access, continue on with the PCI. The monitor tech is the one that's going to be accepting those orders and starting the orders from the ER physician to be able to start the case. If we don't have an order to start the case, then we can't put them in an x-ray. We don't know who they are. We can't go any further than that. So they're going to be the ones working with that. They're also going to be accepting the patient, helping put them on the table, get all their leads and blood pressure cuff, everything set up. The nurse is going to be the one that's going to be receiving report. I don't know if you guys picked this up. On the bottom here, there's an added little handoff section. It's very small, and it's not saying